Good morning, and thank you for staying in here. I think this is the first time I've spoken in a room that actually has windows, and I was hoping it would keep raining. I know it's almost lunchtime too, so we'll try to make this worth your attention for the next 45 minutes or so. I would also say I'm thrilled to be speaking among other people I respect so much, and I was very happy with Kelly's leading the charge on owning these diseases from the neurology standpoint. And I think one of the themes that you will see in any course discussing neuroinfectious diseases is how much overlap there is between the talks, because you don't know when you see the patient whether it's a meningitis, encephalitis, or both, whether it's infectious at all, or autoimmune, or neoplastic. And so, that's okay. We need my timer. Keep me honest. So I am going to discuss these things. I'm not going to read through each of these bullet points, but this is the agenda. So encephalitis obviously is inflammation of the brain parenchyma. It can be diffuse, focal, or multifocal. And the pattern can definitely give you clues to whether you're dealing with an infection or an autoimmune process, as well as what kind of infection. It can also involve many other parts of the central nervous system. And I think my favorite term is meningoencephaloradiculoneuritis. I think the more syllables, the better. But again, you don't always know before you have all your studies what syndrome the patient fits into. So viral encephalitis is what many of us think of when we hear the word encephalitis. We think viral encephalitis. These patients have headache, fever, altered mental status, and they often have other neurological features, including behavior change, language impairment, often some focal findings outside of the mental status exam, including hemiparesis, visual field deficits, and often seizures. Obviously, that set of symptomatology is not specific to viral encephalitis, although the fever certainly would make you lean that way. So Arun Venkatesan and others who work in the viral encephalitis consortium put together these criteria, and I think they're very useful for research and conceptualizing, not just for research, but for thinking about the category of encephalitis. So Dr. Roos mentioned this earlier as well, I believe, but so major criteria include altered mental status. Obviously, not all patients with encephalitis have altered mental status. Some of them have focal findings that don't involve cognition, but that was acknowledged in these criteria. But nonetheless, other minor criteria, again, fever, seizures, new onset focal neurologic findings, inflammatory CSF, loosely defined, brain imaging, or EEG suggesting encephalitis that's not otherwise explained. And it's purposefully broad to try to capture inflammation of the brain parenchyma, and allows for, obviously, if you get an HSV PCR, then you don't have to meet all these criteria. You definitely have HSV encephalitis. So, talking a little bit about the epidemiology and pathophysiology underlying infectious encephalitis. So, viruses, like I said, are what comes to mind as the leading cause of acute encephalitis. So, we think of HSV1 primarily because it is treatable, and you have very different outcomes if it's treated early versus late. So it's a high valence, high stakes diagnosis to make. And it is the most common cause of sporadic viral encephalitis. It's also a relatively non-discriminating pathogen in that it will affect both normal and immunocompromised hosts and can occur any time of year. West Nile virus is the most common epidemic viral encephalitis in North America. Just in the course of a couple of decades, it sort of marched across the North American continent, and this is just a world map showing the distribution. So West Nile is something you have to really consider in any patients. It's not a geographically restricted virus anymore, although obviously more common in mosquito season. Worldwide, Japanese encephalitis virus is actually the most common. It's most predominant in tropical areas in Asia, particularly in the monsoon season. Chronic viral encephalitis is actually very rare. Probably HIV is the most common cause, but it's not. The pathophysiology underlying chronic encephalitis and HIV has probably multiple different mechanisms, and we don't always think of it in the same way as we do productive infection of neurons, as you see with some of the other viruses. Another one that was highlighted yesterday, if any of you attended the subspecialty in focus, measles is an oldie but a goodie, and certainly with recent outbreaks and incomplete immunization, it's something to keep in mind. Certainly a zebra, when you hear the hoofs, you should still look for horses, but if you don't find any, something to keep in mind. So like Kelly, I think of the host first as sort of what are the possibilities in this particular patient, and anything that affects their immune status should impact your thinking. So age by itself, something that we all face. As I was laughing about earlier, I look forward to the day when I have to be covered with ampicillin as well for bacterial meningitis. But also HIV, I would just make a plug here. I think every time HIV testing comes up in any audience, I say every patient should be tested for HIV if they do not have it somewhere in their record already, regardless of risk factors. So that's a national guideline that the cost-benefit is well in favor of screening for HIV, regardless of risk factors. I've had a 75-year-old woman with no risk factors who ended up having HIV, and obviously drastically changes your management and diagnosis. So the other causes are listed here. In particular, we're seeing more and more newer immunologic agents, both within neurology and MS, as well as in connective tissue disease. And it's something to keep in mind, particularly those patients who are on multiple immunomodulatory agents. You may not associate any one with infections, but often in combination, they have complex alterations in their immune system. And then vaccination, again, going back to the measles, it's really important to take a history when you are not seeing the more obvious things that could be going on. Going back to that history, was there any gaps in their vaccination history? Do they come from a country where they may not have had access early on to vaccination? And then the flip side of the host is that, what is the innate host is the exposures that host has. And so geographic origin, travel, what time of year is it? Whenever you see questions on the boards that has anything to do with the season or location, you know that it's a neuro ID case. Little pearl. So pathophysiology-wise, viruses actually can cause encephalitis through several different mechanisms. There's direct viral invasion, and I think West Nile virus is a good example of that. You get it injected by the mosquito, you get viremia, and then it makes its way in a small number of patients, actually, and compared to all those who are infected with West Nile. Small minority actually have a neurologic or neuroinvasive disease. Then there's a peripheral infection. I think rabies may be the only one in this category where you get an inoculation and then it makes its way along the nerve. Bystander damage occurs with a lot of different infections where you have the virus. It may not be replicating in the neuron and actively destroying it that way, but its presence generates an immune response wherever it is found. And then molecular mimicry is probably the most common mechanism through which an infection can cause an encephalitis, and it's actually not direct infection, but a para-infectious process triggered by the infection. So now I want to go through a differential diagnosis for infectious encephalitis. Like the other speakers, I come to these cases from the standpoint of having a patient in front of you and you don't know whether it's infectious, autoimmune, or neoplastic. And so there are things that you should always consider, and this is just my approach. So here's a list of some of the things that can mimic infectious encephalitis. I'm going to go through each of them briefly. So encephalopathy. So encephalopathy is a bugaboo of our residents who get called by the medicine service for a patient who was just started on benzodiazepine and who has a UTI. So we all are well aware of the possibility that things outside the brain can make the brain not function normally. This is one of my big shticks with Lyme and the concept of Lyme encephalitis. I've heard Dr. Halpern, who's going to talk later, talk about this, but the whole concept of you may have an infection somewhere in your body. You can have alterations in your cognitive functioning, but it doesn't mean that the infection is directly doing it. So some ways to distinguish encephalitis from encephalopathy I think are obvious to this audience, but just to make them explicit. So they may have an altered mental status, usually don't have fever, at least not at the time that they present with the alteration. They can have headaches, but headaches, focal findings, and seizures are much less common in encephalopathy than they are in encephalitis. The EEG can be useful in showing a general slowing in the classic triphasic waves that are seen in several forms of encephalopathy. MRI and CSF, by definition, are usually normal, and if they're not, you certainly should rethink your diagnosis. And generally, treatment is directed, obviously, at the underlying course. So you can't talk about, you can't have a talk that includes HSV encephalitis and not also at least mention acute bacterial meningitis. Those are the two neuroinfectious disease emergencies, and both are high stakes, both are key to diagnose and treat early. And so my thinking on every patient who comes in with possible encephalitis is, could this be HSV? Could it be bacterial meningitis? And if the answer is yes, even if it's not likely, that really guides my approach. So bacterial meningitis, as I mentioned, a lot of these syndromes overlap. Even though the inflammation is primarily in the CSF, it's right in contact with the cortex, and so you obviously can have altered mental status with meningitis. So these patients classically present with fever, headache, altered mental status. They tend to have a much more fulminant course than viral encephalitis. So in the developed countries, most patients with acute bacterial meningitis will present within 24 hours to the hospital. So symptom onset to hospital arrival is usually within 24 hours. They obviously have prominent meningismus. Neuroimaging can be normal early. CSF is obviously the key, and in general, there's much more inflammation than you would see in predominant encephalitis. And obviously the CSF can give you much more information about the microbe you're dealing with. Again, if I think there's a possibility of bacterial meningitis, I get them started on broad spectrum coverage while I get my other studies in. So as opposed to the chronic meningitis that Kelly described, for these acute presentations, you shoot first and ask questions later. You all know this table by heart. I just want to point out a couple of things that I think have been mentioned in some of the other presentations as well. So your opening pressure tends to be higher in bacterial compared to viral. Obviously, we're talking about acute presentations here, so the fungal and TB are also causes but aren't on this table. Glucose, generally low, although the caveat, as mentioned earlier, there's a list here of some viruses that can also give you low glucose. Your white blood cell count is generally more elevated in meningitis than encephalitis, and in fact, some encephalitis patients may have a normal white blood cell count, although that's not typical. And then the classic distinction is the neutrophilic versus lymphocytic, but always there's no, as Kelly said, there's no firm rules that you can completely rely on. And here again are a list of those viruses that can cause a neutrophilic pleocytosis. So HSV, this is something that I always put early because you should be thinking about it early. So typically patients present over days as opposed to within 24 hours as the bacterial meningitis. The focal findings are common, and as you all know, there's a predilection for limbic structures, and so the orbitofrontal and mesial temporal lobe. So the imaging with a fever and the subacute presentation, I treat these folks while I'm waiting for the PCR to come back. EEG, they still ask this a lot on the boards, even though it's not the way we typically diagnose HSV anymore. And it's still on the right exam for you, for the residents in the audience. CSF PCR has become the de facto gold standard. Obviously, biopsy has traditionally been the gold standard, but in my time as a faculty, I don't think I've ever seen a case that was diagnosed by biopsy, although it is sometimes necessary still. As previously mentioned by Dr. Aksamet, no test is perfect. And so CSF PCR gives you confirmation. One little plug I would make is that if it's not positive and the patient looks like this, that has no impact on my treatment, and I'll do another tap 2 days later, and oftentimes that will be positive. If that tap's negative and the patient looks like this, I give them 21 days of acyclovir, and I look for other stuff, but the stakes are too high to stop when your pretest probability is so high. ADEM, something that I think all of us are familiar with, and obviously much more common in children. One of the tricky things with ADEM is that they often do have a viral syndrome, and including fever. However, the fever and viral symptoms usually precede the neurological symptoms by several days or weeks, and it can also happen obviously after vaccination. It's more common in children, but definitely happens in adults. One of the things that I think is not highlighted so often when I read or hear about ADEM is that a lot of these patients also have other demyelinating syndromes at the same time. So I've had a handful of patients who've had MRIs like this with no visual symptoms, but then when we did testing, either neuro-ophthalmological evaluation or visual evoked potentials or just examination and looking for an APD, they often have optic neuritis concurrently. And then, as the name suggests, myelitis is often a concurrent syndrome. So the CSF and EEG could be exactly the same as they are for viral encephalitis, so it's not often entirely helpful. The MRI pattern can be useful if you see multifocal white matter lesions and this, I'm not sure if it's coming across here, the sort of open, this lesion here, the open rim enhancement, sort of classic migrating demyelination with the incomplete ring sign. Obviously not super specific, but it can be helpful. So as you all know, treatment is with corticosteroids. So encephalitis can be the first presentation of a systemic autoimmune disease, and I don't need to tell this audience now that you've all seen a case of basal meningitis and hypothalamic involvement with sarcoidosis. Headaches are common, seizures are common, and cranial neuropathies should all make you think of sarcoidosis. Tends to present a little over a longer time course than viral encephalitis. And the CSF pattern could be indistinguishable. It's usually an aseptic meningitis. Sometimes they have a low glucose, and that's something that could clue you in. The MRI, you often will see this involvement of the diencephalon. or the cranial nerves. Treatment is with steroids, and for refractory or very severe cases, more and more folks are using TNF inhibitors such as infliximab. Behçet's was mentioned earlier. I think that's a good one to have in your back pocket, although it's not very common in Caucasian populations. So it's more frequent in the Mediterranean and Asian ethnicities. The classic presentation was with oral and genital aphthous ulcers, and that's indeed part of the criteria for making this diagnosis. The patients frequently present with headaches and corticospinal tract signs. I don't think it's well understood, but Behçet's has a particular predilection for the brainstem corticospinal tracts. So I've had several patients who have this kind of picture with inflammation. It's often asymmetric, extending up the corticospinal tracts through the cerebral peduncle into the internal capsule and spilling over into the thalamus. CSF in these folks can actually be neutrophilic, so it's one of those asterisks by the CSF profile to keep in mind. The treatment, again, is similar actually to sarcoid with corticosteroids, and this is thought to be a vasculitic process, but the driving force is TNF driven, and so it's an inflammatory, auto-inflammatory type disease. So the TNF inhibitors are also used. This controversial syndrome, Hashimoto's encephalopathy, which has significant overlap, and some people equate to steroid responsive encephalopathy with autoimmune thyroiditis. So fluctuating behavioral and cognitive disturbances, negative microbiological studies. The TPO and TGA are there by definition, which I think most of us now consider a marker of autoimmunity and certainly not pathologic. And I think as we get more sophisticated in terms of looking for bad humors, the category of patients that fit this will probably diminish as we find more specific CNS targeted antibodies. It's defined also, obviously, by its response to corticosteroids. As Marty Samuels always says, no one dies without steroids, as pointed out previously. I don't know if I fully agree with that explicitly as stated, but I certainly think that we should not have we shouldn't be too queasy about giving someone steroids when you're worried about an infection, because there's very few infections that you're going to cause catastrophic damage by giving someone steroids, at least in a short term. So this has been all over the conference, and I think is great to make explicit in a neuro-ID talk that we have, because in real life, you don't always know whether you're dealing with an infectious or an autoimmune encephalitis. So I just am highlighting the two most common antibody-mediated encephalitis that we know about now. And I think in 10 years, we'll probably have a much longer list. So this used to be called voltage-gated potassium channel encephalitis. We now know the antigen is this leucine-rich glioma inactivated 1. Now you know why everyone says LGI1. And this causes antibodies against this are associated with limbic encephalitis. So these patients have this secreted, LGI1 is a secreted neuronal protein, and patients can present basically with limbic symptoms. So it's one of the mimics of HSV encephalitis. Seizures are very common. Patients will often have mesial temporal changes. You can see some enhancement here, and then there on the coronal post-contrast. Their CSF can be pretty unimpressive at times, and it can sometimes even normal. This is one of the antibodies that is often present in the serum, but as many people have emphasized over the course of the conference, when you suspect an antibody-mediated encephalitis in particular, you should always check the CSF as well. These patients, I would all put on acyclovir till I get that diagnosis. As you can imagine, the LGI1 antibody is not going to come back within 8 hours like your HSV PCR is. So anybody who presents with an acute encephalitis with temporal lobe predominance gets acyclovir. It's a very benign medication as long as you're tanking them up with fluids. Treatment for LGI1, most of these are not paraneoplastic but are autoimmune, and they get immunotherapy with steroids or IVIG, and sometimes this tends to be a monophasic illness, although there are some cases with protracted or recurrence, and then you might need to turn to stronger immunosuppressives. And then obviously, because of the limbic predominance, seizure prophylaxis is often, lifelong seizure prophylaxis is often necessary. So the other one that I think is not news to anyone in neurology now is anti-NMDA receptor encephalitis. What Dr. Dalmo and others have taught us with more and more experience of these cases is that there tends to be a fairly distinctive clinical syndrome. These patients often present with an infectious prodrome, and that probably is related to the basically stirring up the hornet's nest. Someone has a predilection to make these antibodies. Some unrelated infection gets their immune system stimulated, and then they start producing them. They classically will present with psychiatric disturbances, and I'm sure many of you have colleagues in psychiatry who have seen this. And then once they develop seizures, they say, whoa, wait a minute, let's look at this. So it is a global encephalitis. So a lot of people think of it as a limbic encephalitis. It actually causes global cognitive dysfunction and can affect multiple parts of the brain. They often present with abnormal movements, oral, facial, as well as limb movements, which are not seizures in most cases. They do independently develop seizures, and then they progress on to have autonomic dysfunction, sometimes hypoventilation, and I've had at least 2 patients with this syndrome who we've had to emergently intubate because of just rapid fluctuations in their autonomic function. And then they can progress to catatonia and coma. And MRI in this setting can be completely normal. In fact, that typically is normal. The EEG may be nonspecific, although it often is abnormal. CSF, again, not impressive. And then the diagnosis in particular for this disease rests on CSF IgG to the NR1 subunit of the NMDA receptor. And you may have seen some articles out from some psychiatrists who basically took large populations of psychiatric patients. I think it was in Germany, it was in Europe, and basically screened for NMDA antibodies. And they detected something like 10% of patients with otherwise ill-defined psychiatric illness. So they actually used IgM and IgA, and they didn't use CSF. And so I think it's important just to be aware, as more and more of our colleagues in psychiatry become aware of this disease, you're going to get I've had already at least 5 patients whose parents did not, were concerned. It's kind of like Lyme with ALS. When the stakes are so high for a bad diagnosis, you're going to really cling to the one that sounds better. So I've had several patients with typical schizophrenia who wanted to come in and be tested for this, thinking that they had a reversible process. I would look back to this and say, did the patient have any of these, and how long has it been going on? And then to make sure if you do test, you send CSF because the serum is not specific. In young women, there's often a teratoma associated, and removal is curative. And those who don't have a teratoma, immunotherapy, often with rituximab, can be necessary. Okay, so I think in the remaining 25 minutes or so, I'm going to move more explicitly into the infections. So there are certain systemic clues to look for to help you. So extra CNS clinical clues, skin. I forget who said this. Someone earlier in the conference pointed out that none of us went into dermatology because I think Karen said it about the GI symptoms and vomiting and diarrhea, but I would certainly say dermatology was not for me, but it's important to be able to recognize certain patterns. So diffuse rash can occur with enterovirus or childhood exanthems that can be associated with encephalitis. This is a patient who I had with shingles, who then later developed a myelitis. So you should think about that with VZV. Pharyngitis or URIs, think influenza. We've had several cases of patients with acute hemorrhagic leukoencephalopathy after influenza. There's particular strains that are associated with that. Parotitis, oophoritis, orchitis, classic boards. You got to think about mumps, but also with pancreatitis, think about mumps and LCMV. I was not aware of this one until a couple years ago when I was reviewing to give a similar talk. St. Louis encephalitis virus, for unclear reasons, patients are often have urinary symptoms early on. So if you want to impress your colleagues in infectious disease, you can point that out. I'm sure you see St. Louis encephalitis every other week. Joke. How often do you see St. Louis? Yeah. Okay. Cord involvement. Great point. These several of the arboviruses are associated with an anterior horn syndrome, but it can obviously extend to the lateral columns where your autonomic fibers are. So conjunctivitis, you should think about adenovirus and St. Louis, and then retinitis, as mentioned in the earlier case from Kelly, CMV. West Nile virus can also be associated with retinitis. So what are the other thing that I like to focus on in trying to figure out the possible etiologies is if I know there's brain involvement, what part of the brain, and is there a particular pattern to it? Both some viruses and some autoimmune processes have this amazing tropism and we're taking advantage of that in other non-infectious fields for therapy delivery, but it's something to keep in mind for diagnosis when you see a particular pattern. So we talked about HSV, and that's fairly ingrained, I think, in everyone's mind. Your limbic structures, the anterior and medial temporal lobe and inferior frontal lobe. This is a short list. There are a long list of HSV mimics. This is the short list. And HHV6, I would say, is a ubiquitous virus, and if you look for it in all your patients, you're going to find it in a lot of them. It really causes this more in the post-transplantation patients who are significantly immunosuppressed. Syphilis, Christina Mara always makes this point that you can see this case here. Patients can present identical to HSV. So when you do that, you get them started on acyclovir, you do your LP, and you cannot track down the PCR to confirm it, think about these other diagnoses and do a serum treponemal antibody. You can scratch that one off your list fairly easily. As I mentioned, these two autoimmune processes can also present very similarly, although I would say in my experience the MRI is usually less impressive with the autoimmune encephalitis than it is with the infectious. Basal ganglia. How many people have seen West Nile basal ganglia? So a handful. So this is, I think a lot of people are aware of this. The flaviviruses in particular seem to have a predilection for the basal ganglia. So it's kind of subtle here, but you can see there's a little bit of increased T2 signal in the caudate and putamen here. This was a patient with West Nile virus encephalitis. Again, influenza can do this, but it tends to be a little more fulminant and it's often hemorrhagic. Cerebellitis. So when I think of cerebellitis, I often think of little kids who have chickenpox, and then a few days later, their parents freak out because the kid can't stand up. I don't know if any of you have seen that. I remember a case in med school, and it really ingrained in my memory just what it means to have cerebellar ataxia. Couldn't sit on the side of the bed, and it also has strong valence because I did the LP on this kid. And I probably wouldn't get to do that anymore as a medical student. So VZV, classic cause of post-infectious cerebellitis. EBV also, it's probably mostly a para or post-infectious phenomenon, except in immunocompromised patients who sometimes can get direct infection. Again, St. Louis encephalitis virus, not a common one, but something to think about. The list is long here. Certainly paraneoplastic cerebellar degeneration can cause, it tends to be more subacute, and they often have normal MRIs, at least early on. This patient actually was a patient, an older patient of mine who ended up having listeria. So rhombencephalitis, or more broadly speaking, posterior fossa encephalitis. Again, it's a similar list because the cerebellum is obviously part of that structure. And then I think listeria is something that we often think about here. In terms of the non-infectious causes of rhombencephalitis, I think NMO is really becoming more prominently thought of, particularly the aquaporin-4 rich periaqueductal structures. So if you see someone with bilateral optic neuritis or who has transverse myelitis and they've got brainstem involvement, these patients often have profound nausea that is really hard to treat. You should always think about NMO. ADEM can affect any part of the brain and is something to consider. And then particularly aggressive form of ADEM, Weston-Hurst is the eponym often given here for acute hemorrhagic leukoencephalitis. So brain and cord at the same time. Again, you have to think about ADEM because it's in the name. But as mentioned previously, these arboviruses, I think the pointer is on the way out, and I'm not as charming as Karen to get more. I don't need it, Joe. It's okay. So you should think about the arboviruses in particular. Think poliomyelitis, which thankfully has been eradicated most parts of the world, but there are some related enteroviruses, in particular EV71. There was this, thank you. It's probably the operator, not the equipment. The last year, last 1 or 2 years, there was a big hype over this a syndrome that was happening predominantly in children around EV68, and it was never, in Colorado they actually had a cluster where they had very good evidence that there was a relationship, but nationally this syndrome of a post-infectious encephalomyelitis with some anterior cord features never through the CDC was never fully borne out, but I think there are some emerging things here like the EV71, which is common in other parts of the world, in particular in Asia, which can cause a syndrome exactly the same as a classic poliomyelitis. So things to keep in mind. Rabies, there's I think a couple of residents from our program here. We had a rabies epidemic a few years ago. We had 3 cases in 1 year. One was a gentleman who came in with dysphagia. And turns out the dysphagia was hydrophobia. And he had a classic case. But we had another one who presented with a rapidly progressive flaccid paralysis. And it wasn't the first thing that came to mind, but ultimately that was the diagnosis. The patient actually had been from Brazil and bitten by a dog in Brazil 20 years ago. They actually determined that the virus was from the virus type was from his town in Brazil. So that will help you sleep at night. If any of you have had a bad exposure, talk about latency. So now I just want to talk a little bit about the approach to diagnosis. So there are a lot of different approaches here. I have found that in general, I am a little more targeted than most of my infectious disease colleagues. Is that your experience? So everybody obviously should have these basic testing done. Usually you're not going to get your answer from the basic testing. There are a couple of clues. I think Karen's slides may have mentioned this, but hyponatremia, that's common in LGI1 encephalitis as well as in TB from the SIADH. CBC, coagulation studies, as I mentioned again, HIV. So if you don't remember anything else from my talk, I want you to test HIV antibody in any of your patients who don't have it already. If you do it in everybody, it takes away whatever stigma or hesitation you might have. You say, I do this in all my patients just to mark it off the list. And then key, get some samples saved and do acute and convalescent testing. So all patients have to have CSF. That's how you define the syndrome. And as Kelly mentioned again, I just assume that everyone in this audience knows to get and will always get an opening pressure. I have had battles with the ED with challenging LPs where I ended up sitting them up, getting the needle in, and then putting them back down and having them straight their legs out. I think the point about the CSF popping out the top is telling. My general take on that is if the patient's awake and talking to you, it's probably okay, and like in your case, they probably need the CSF removed. If the patient is comatose and that happens, then you better get neurosurgeons there in a hurry. So gram stain, bacterial culture, and PCR. So my approach is look for the emergencies, so acute bacterial meningitis and HSV encephalitis. Look for the actionables, so VZV has a treatment. And then look for the common that can make you call off the hunt and not go crazy, and that's the enterovirus. So even though enterovirus predominantly causes meningitis, it's so common that it can sometimes cause a meningoencephalitis. In the right season, I will definitely check at the outset in the first tier the West Nile. In Massachusetts, you don't have a choice of which one. You send it to the state lab and they do all of the arboviruses. Again, if you have an IgM in the CSF, that can actually be diagnostic because it's large molecule and doesn't generally cross unless it's active CNS infection. I will get oligoclonal bands and IgG index. I think this is important, particularly for the autoimmune encephalitides. Commonly, that's one of your only evidence that there is some kind of immune-mediated process going on, that you have something that's being made in the CSF, even though it's obviously not a specific test. And then I think you all probably live by this. If you're going to stick a needle in there, get as much as you can and store it. So I don't go crazy until I see the profile come back, and then I target the rest of the testing that I do. So based on the demographic, their immune status, the clinical findings, and their CSF, then you can start making more rational choices. I'm not going to hug you like Karen, but thank you. I'm a hugging kind of guy, but things to consider, serologies for EBV. I've had 2 cases of EBV cerebellitis, one of which ended up being a New England Journal CPC and got better with IVIG. Syphilis, again, it's an easy thing to rule out, so just serum treponemal antibody. I think in many hospitals now, because they've gotten more efficient, it's now cost effective to do the treponemal antibody as your screen, because it is the RPR can turn negative later or the non-treponemal test can turn negative. So I usually start with the treponemal antibody, and if that's positive, then I send an RPR. So if you're thinking about syphilis and you want to rule it out, just start with the treponemal antibody. Same thing for Lyme. If the Lyme serology is negative, I'm done until they get referred to me later with a post-infectious cognitive cloudiness. I've never had a case that turned out to be Lyme that had a negative antibody. On the flip side, if the patient presents in Boston in the summertime with an aseptic meningitis and a facial palsy, I don't even bother checking the Lyme. I just will treat them for Lyme. Mycoplasma is a tricky one. It's often cited in association with encephalitis or encephalomyelitis. I think almost all these cases are para-infectious, and as borne out by the lack of direct evidence of CNS infection. There is a PCR you can do on the CSF, but it's something to think about. We had another case of a young woman who had this profound encephalomyelitis, longitudinal myelitis, flaccid quadriplegia, and who we ultimately we treated her for the mycoplasma because she did have a respiratory illness, then developed this profound para-infectious syndrome, got steroids and IVIG, and about 2 weeks later walked out and resumed her college studies. So I think mycoplasma is something to think about, but it's often either a trigger or a bystander and not the culprit directly. We don't see a lot of rickettsia, but I think you have to put that on your list, particularly if there's rash. And then whenever you have Lyme, you got to think about the Lyme. Lyme likes to roll with its buddies. These two don't pick on the nervous system as much as Lyme does. But important to think about if your Lyme is negative. Coccidioides, desert Southwest, Central and South America. So acute and convalescent serologies will help you, particularly even if you can't identify something that's treatable. It's always good to have an answer both for the patient and for resource utilization. You should think about a blood smear, again, for the parasites. Babesiosis is the other thing that hangs out with Lyme, looking for atypical lymphocytes. And then I am a big proponent of the cryptococcal antigen as well, and I'm moving more towards doing this as one of maybe even a first-tier test because it's actionable, and as we're learning more and more, it can happen in immunocompetent folks. So something to, I would say, start thinking about more often. So again, the CSF testing to target, again, maybe I might next time bump that up to my first tier CSF test to do the cryptococcal antigen. The mycobacterial smear and culture, I will say my one take on TB is when you suspect it and everything's negative, that's a pretty good indicator it's probably TB. So I generally will treat it, particularly if I'm going to immunosuppress someone for a presumed autoimmune process. And in my experience, the PPD and the interferon gamma release assay, my infectious disease colleagues tell me not to rest assured with a negative test for latent TB. So I struggle with that as well, Kelly. So the VDRL and FTA, I only test if the serum is positive. The PCR for EBV and Bartonella and mycoplasma, again, in the specific context. And that I do send the IgM for the arboviruses. So in immunosuppressed folks, I would add these tests down here, the CMV, HHV6, as I mentioned, particularly in post-transplant, EBV and JCV for PML if the picture is telling. I think shout out to Michael Wilson in the back who published this and nicely landed also on the New York Times after using deep sequencing of tissue. I believe this was from CSF, was it CSF? Patient with an underlying immunodeficiency syndrome who had this progressive CNS illness, and everything under the sun had been tested for using computational methods, basically sequenced everything and said what's here that shouldn't be, and diagnosed leptospirosis and saved the patient. So I think this has promise and something to be aware of down the road. So lastly, how do you treat these folks? So a lot of this is all in your syllabus as well, so I'm not going to focus too much on the specific dosing. Everyone here knows the empiric coverage for acute bacterial meningitis. Again, ampicillin for those over age 50 or immunosuppressed. HSV encephalitis, if you start these meds, you're almost always going to start this one at the same time, and vice versa, because you don't know what the underlying syndrome is until you get the CSF and imaging. For, like Karen, I sort of doxycycline just in case sometimes. It will cover these atypical bacteria that might not be as well covered otherwise. So again, I'm not going to go through this table. It's also available in the syllabus. I do want to just point out the folks, Don Gilden and others in Colorado, emphasize considering a higher dosing of acyclovir for VZV. CMV, I think when you get down here is when you start calling your infectious disease colleagues for a little help with the management. I had one patient who worked in a scientist who worked in a monkey lab who came in and ended up having herpes B virus. So that's not something I would expect to ever see again in my lifetime, but you certainly can, it's good to know about these things even if you never apply them, if you don't know it exists. People who work with lab monkeys who come in with encephalitis, you should think about herpes B. In general, I think it's very important to have a good relationship and a good familiarity in the ICU with these diseases. And I know there's some, at Hopkins, they have a model where they have a collaborative group who, neuro-ICU and neuro-infectious specialists who take care of these patients together. So almost all of them are going to need anti-epileptic medications. You're going to want to monitor for intracranial pressure and cerebral edema. One of the things I didn't touch on specifically was HSV encephalitis. We've seen in TB, in acute bacterial meningitis, there's this emphasis on the neurological injury is the inflammatory reaction to the infection. And so there's been a mixed evidence over the years in HSV in terms of steroids. Was waiting and waiting and waiting for this European study. I just emailed the chair last week because we had a patient with HSV who ended up getting a hemicraniectomy. But the question was addressed to me, what about steroids? Is it going to worsen the viral replication? The patient's swelling, starting to herniate. Basically, they were planning this randomized controlled trial in Germany and they couldn't enroll enough patients. So the bottom line is that we probably should think about hemicraniectomy in these patients. Steroids are probably, I think will probably ultimately gain favor, but it's a gray area and you have equipoise at the moment in the literature. There's actually evidence on both sides. So I don't routinely give patients steroids, but if they start to have herniation, the devil in front of you is the one that you need to address rather than the devil you don't know. Correcting the hyponatremia, and then careful cardiorespiratory monitoring and support, because these patients can tank suddenly. I think that's the end of my slides. Thank you very much.